So now we're going to be discussing shock. So we define shock as a state where certain organs within our body are receiving an insufficient blood supply to be able to really conduct the work that they need to do. So the supply of perfusion to those areas in terms of oxygen and nutrients is not meeting their needs, resulting in the failure of those organs. So to really begin to look at the different ways that shock can manifest, we need to develop a basic schema of how blood is sent throughout our body. So without getting too anatomical, we can do a basic drawing to put in the heart and then the aorta coming off of the heart, and we'll just say that the blood branches off in basically 3 different ways we'll think about for this schema. So the blood can branch off to the brain, to the kidneys, and also out to the periphery. So here, the skin. It's also important to remember that blood comes off of the aorta back to the heart, and we'll also include in there sort of to other vital organs. And then we have the venous return from each of these different locations. In the event that our body isn't able to maintain perfusion to all of our different organs, there's a tiered system by which blood flow is allocated. So our highest priority is going to be the brain, closely followed by the heart and other vital organs. Lower down on the ranking is going to be our kidneys, and therefore as a result of this, the kidneys are at risk for acute kidney injury, or AKI, from low perfusion in shock states. And furthest down on the list is our periphery, our skin and our muscles. And classically in shock, we think of individuals undergoing shock as having cold and clammy extremities, and that's a result of the decreased blood flow to the peripheries that can occur in a shock state. So in our discussion of shock today, we'll focus on 3 major variables. The first variable is central volume status, and what that means is really the volume status that's going to be present in our central large veins, so like our inferior vena cava, and the large veins flowing down that form into the superior vena cava, namely the jugulars. So the ways that we assess this clinically are going to be either by taking an ultrasound probe, sticking it on an individual's back to take a look at how distended their central venous system is, or more commonly we'll take a look at someone's neck to look for elevated JVP, which would suggest sort of a block up there. Second, we're going to take a look at peripheral or systemic vascular resistance, which we'll abbreviate SVR. This refers to how constricted blood vessels are really out in the periphery, which extends to affect the entire system. And finally, we'll look at the variable of the cardiac output. So today we're going to discuss several different categories of shock: distributive shock, hypovolemic shock, and cardiogenic shock, along with several of the more common subcategories of distributive shock: septic shock, toxic shock, anaphylactic shock, and neurogenic shock. And using the 3 different variables we've discussed, we're going to build one of those arrow diagrams that often cause so much distress on the test, but we're going to put it together piece by piece. Alright, so the first form of shock that we're going to talk about is a form of distributive shock known as septic shock. And septic shock basically has as its initiating event an infection by gram-negative organisms. And we talk in particular about gram-negative organisms because these organisms have as a component of their cell wall lipopolysaccharide, or LPS. And LPS is a molecule that is highly recognized by the innate immune system and results in significant immune system activation. In particular, it results in the production of a number of inflammatory cytokines, namely the ones we talk about in general in the context of inflammation: IL-1, IL-6, IL-8, and TNF-alpha. So these inflammatory cytokines work as vasodilators with the goal of increasing blood flow to the area where they're produced. Now with a local infection, this is a great idea because this increased blood flow to an area, say cellulitis, is going to help bring more white blood cells to the area to fight infections, and also the vasodilation will help slow down the speed of the blood flow to help those white blood cells leave to fight the infection. However, it isn't such a great idea with a disseminated infection because in this case the result is going to be widespread vasodilation. Turning back to our schematic, vasodilation, as we've talked about, results in a decreased systemic vascular resistance. In other words, it's going to vasodilate this peripheral area and greatly increase, therefore, blood flow to this area. So this is going to be our primary problem in this case, this dysregulated decrease in systemic vascular resistance, which causes a lot of our blood to be flowing to an area where we really don't need it. So our body has a response to this, and its primary response to try to overcome this is to ramp up our cardiac output. And by ramping up cardiac output, we get more blood flow throughout the entire system. A lot of that blood flow is still going to be going incorrectly out to the periphery due to that vasodilation, but that at least helps make sure that more blood is flowing through the system to get to our vital organs. So now, starting to build our arrow diagram, we can see that our primary insult is this abnormally decreased systemic vascular resistance from the inflammatory cytokines, and our primary response is going to be increasing our cardiac output. In terms of our CVP and JVP, we start with a relatively normal blood volume, but a lot of that blood volume is going to be out in the periphery, and in addition, between sweating and other processes, we could get some decrease. So we're going to say that this is sort of normal to low. So our second form of distributive shock is toxic shock, which is extremely similar to septic shock, other than a slight variation in the causal organisms and the toxin. So in this case, our organism is classically Staph aureus. And Staph aureus produces an exotoxin that is released out into the body, toxic shock syndrome toxin 1. And this toxic shock syndrome toxin works as a super antigen. So thinking to our activation via our MHC system, most antigens actually only activate a small subset of T cells, actually a very, very small subset that leads to inflammation and reaction. This toxin is going to broadly activate tons of T cells, leading to widespread immune activation and cytokine release. And if you had to guess the cytokines, you're right, it's the same ones again. So IL-1, IL-6, IL-8, and TNF-alpha. So now again, for toxic shock, our primary insult is going to be this decreased systemic vascular resistance as a result of all these inflammatory cytokines, and our primary response is going to be trying to increase the cardiac output in the same way that occurred in septic shock. So now looking at our arrow diagram expanded for toxic shock, again, our primary insult is decreased systemic vascular resistance from inflammatory cytokines. Our primary response is going to be increasing our cardiac output, and yet again, for the same reasons, we'll find that our CVP to JVP is low normal to low. So our third form of distributive shock is anaphylactic shock. And in anaphylactic shock, we get the binding of an allergen, an antigen, to mast cells, which results in massive degranulation and release of preformed histamine. And histamine is a potent vasodilator, so it leads to widespread systemic peripheral vasodilation. So now again, with anaphylactic shock, we are getting a decreased systemic vascular resistance as our primary insult, and again, we see our heart respond by increasing cardiac output as the primary compensatory mechanism. So now updating our arrow diagram, we're really beginning to see a pattern develop within distributive shock, decreased systemic vascular resistance as the primary insult, and increased cardiac output as the primary response mechanism. So now, finally, our last distributive shock that we'll talk about today, neurogenic shock. We have some form of often spinal cord injury or central nervous system injury that leads to disruption of our sympathetic output to the periphery. And our sympathetic output is responsible for regulating vasoconstriction. So this deregulation leads to peripheral vasodilation. So now for neurogenic shock, we see this same system, vasodilation in the periphery, dropping SVR, our heart increasing cardiac output as our primary response, just like the other forms of distributive shock. So now finishing up our arrow diagram for distributive shock, I don't think anyone's going to be surprised to see, again, primary insult, decreased SVR, response, increased cardiac output. So now on to a new form of shock, hypovolemic shock. And hypovolemic shock results from a loss of blood volume. So this can happen in several different ways, pretty easy to think about. Either we can be losing blood either internally or externally through hemorrhage, we can be losing blood volume through dehydration, and we can also be third spacing, sending fluid out into our interstitial tissue with edema. And typically our body can tolerate a decent amount of volume loss prior to going into a shock state. We actually can lose up to 10% of our blood volume without even feeling symptoms. And then shock in most individuals is going to occur at around a 30% volume loss. So now returning to our schema for hypovolemic shock, our primary problem is that we're losing blood volume for some reason. And as a result, we've got less blood to distribute to our different organs. And as a result, we use a primary compensatory mechanism that's actually really the opposite of what's happening as a disease process in septic shock. So we actually constrict down our blood flow to the periphery and actually constrict down our blood flow slightly to the kidneys in order to ensure that most of our blood flow is going to our vital organs like our brain. And this is actually a continuous compensatory mechanism that's occurring as we're slowly losing volume. The reason that we see shock here is that we've reached a point where this compensatory mechanism is no longer sufficient to maintain blood flow to our vital organs. So now coming back to our arrow diagram, we said that our primary problem in hypovolemic shock is a loss of volume, and our primary compensatory mechanism is going to be an increase in systemic vascular resistance. However, in this case, we're getting shock, so this isn't able to successfully bring it quite back up, so we're going to see a decrease in our cardiac output on the whole. So the final form of shock that we'll discuss today is cardiogenic shock, and this results in some problem that's basically disrupting our heart's ability to function. And so we can also call it sort of acute heart failure. And breaking down the differential for why this could be happening, this could either be something that's really internal to the heart, like a myocardial infarction, or some inflammation of the muscle leading to myocarditis that means that the heart isn't working, or from external compression, either from a cardiac tamponade or from a tension pneumothorax that's inhibiting the heart's ability to work. So returning to our schema, our primary problem here is going to be disruption of the heart's ability to work as a pump. And as a result, our body is going to have the same compensatory mechanism that we saw with hypovolemic shock. We're going to work to constrict blood flow to the periphery where it's considered less needed, constrict a little bit of blood flow to the kidneys, and that'll help increase the amount of blood flow that's remaining back up to our vital organs, including the brain. And we can just note before we move on that this blockage at the heart is going to result in sort of blockage and buildup in our central veins that would be flowing back into the heart. The heart's not pumping well, so things build up here. So we're going to see an increase in pressure in our central venous system, in our jugular veins, and our IVC as a result of this dysfunction of the heart. So now returning one last time to our arrow diagram for cardiogenic shock, we said that the primary insult was a decreased cardiac output. The primary response mechanism is going to be an increased systemic vascular resistance. And because of that central venous congestion as a result of the heart not working, we're going to see an increased JVP and central venous pressure. And the important thing to note is that here, for cardiogenic shock, this is the only form of shock where we're going to be seeing an increased central venous pressure and JVP. So if we see that, we can clue in that cardiogenic shock is going to be what's going on. And now we've put together this entire diagram.